Good evening, everyone. Thank you for joining us on CII IWN series, Need of the Hour, One-on-One on Heart Health. Today we have Professor Dr. Ashok Seth, Chairman, Fortis Escorts Heart Institute. Dr. Seth has over 33 years of experience in the field, has received national honor of PADMA, Padma Bhushan, is in the Limca Book of World Records, to name a few. He is extremely well respected in his field in India and abroad. We welcome you on board, sir.
Thank you.
It's my pleasure to introduce our anchor for the series, Need of the Hour, Ms. Bhavna Vadera, Chairwoman, CII IWN Delhi Chapter and Vice President of Shiv Group. She's a much sought-after advisor to startups. Her vision, her passion, and her commitment to growing leaders is beyond compare. Without further ado, and I can go on and on for both, it's over to you, Bhavna. Please take it forward with Dr. Ashok Seth. Thank you so much.
Thank you so much, Dr. Glossy. Thanks very much. And thank you so much, Dr. Seth, for joining us today. It is indeed a privilege to have you with us.
Thank you, Bhavna. Great to be with you all.
Thanks a lot. So, Dr. Seth, everybody has heard about, I think everybody is scared. Let me start that way. Everybody is scared of a heart attack. And, we've promised everybody a Heart 101 today. So, without further ado, we're just going to get started. Dr. Seth, heart is the primary organ of your circulatory system. And we know that it pumps blood, controls the heart rate, maintains the blood pressure. Cleveland Clinic likens it to a house. And it says just as a house has walls, rooms, doors, plumbing, and the electrical system, so does the heart. All the parts of the heart work together to keep our blood flowing and sending the nutrients. But we all know that of all the organs, if this one stops, it's game over. So let's dive right into it, and let's touch upon 5 aspects today of this masterclass of understanding our heart. Okay, the first one will be understanding the heart and different types of heart disease. The second one will be the role of family history and what does that really play in our heart health. The third will be understanding heart health and COVID. The fourth will be to understand prevention and what do we do at the critical points. And the fifth will be understanding children and their heart. Yeah. So let's just get right into it, Dr. Seth. What are the different types of heart disease?
So let me not just make it like a class on cardiology. I think it's got to be a conversation around cardiology, and got to be a conversation which is very practical to you all and to all your audience. And has to do with more so with what is going to be relevant to taking care of yourselves every day as far as heart disease is concerned. So I think you said it correctly. I'd say it's the engine of the body. The heart is the engine of the body. It has its electrical circuits, which is what we call the conduction system of the heart, which is what makes our heart beat at 80 per minute or 60 per minute or 70 per minute. And then we have the blood supply to the heart. Think of it as a water supply in the house. And that's the blood supplying the heart muscle itself. Remember, heart is a pump. Heart needs nourishment. Heart needs blood. And that is when we call as heart coronary artery disease. So let's differentiate heart disease into multiple aspects. One, which is birth defects in simple terms.
Sure.
Where the heart did not develop properly.
Yeah.
While in womb, and therefore when a child is born, he's born with certain defects. Could be holes in the chambers of the heart, the wall separating the heart. Could be certain defects where the blood vessels don't arise from the appropriate side. Some of these are serious and not compatible with life in infancy and even during birth or soon after the first 30 days. Others are compatible with a longer duration of life. Some need to be corrected immediately and some don't. That's the congenital heart disease part. The second part is the electrical circuit disturbances. And those are problems which lead to other heart going very fast, heart going slowly, and arrhythmias happening.
Yeah.
And that's the conduction system. And then the most important ones which we talk about are the ones which are supposed to be the blockage in the heart blood vessels supplying the heart muscle. And that's what we call coronary artery disease. And that is what relates to the heart attacks that we see, which actually in adults is the biggest cause of death.
Yeah.
So if we differentiate heart disease, of course, there are many others. Heart is a muscular pump. The muscle can also be affected.
Absolutely.
And therefore lead to thickness of the heart muscle or weakness of the heart muscle. It can be inflamed. Viruses can affect it in a condition called myocarditis. So the spectrum can be huge. But in our own lives, in our everyday lives as an adult, what we face in 90% of the instances or 80% of the instances, I would say, is coronary artery disease, which is blockages in the arteries supplying blood to the heart muscle, and the blockages in those arteries which lead to angina and heart attacks and cardiac arrest.
Wonderful. Thank you for that. Now, I want you to just define for our audiences a little bit, what is actually angina versus a heart attack? Heart attack you have spoken about, and exactly what happens in a stroke, because we're going to hit these terms as we go further. So I just want to, set the stage, clarity for everybody. What exactly do these terms mean?
So angina is a term. I've described to you that the heart itself is supplied by arteries which supply the blood to the heart muscle, because heart is beating all the time and that muscle needs the blood for its maintenance. Now, when the arteries of the heart develop blockages inside due to cholesterol deposits, then the blood flow to the heart gets decreased. Now, at rest, one cannot notice it, any symptoms, because there could be enough blood flowing through these arteries and the supply is enough to the muscle. But on exercise, when the heart is beating faster, more blood is needed, and the heart doesn't get that enough of blood quantity or oxygen quantity through the blocked arteries, and the heart starts feeling a discomfort. And that discomfort on pressure on the chest during exercise or brisk walking, which gradually disappears as one sits down or slows down, is the condition called angina. So it is actually a symptom of discomfort in the center of the chest, going down the arm related to exercise, which decreases or goes away on sitting down. However, a heart attack relates to sudden cessation of blood. So you've got a 70% blocked artery or 80% blocked artery, or I have an 80% blocked artery. So I shouldn't say you have an 80% blocked artery. I say, if I have an 80% blocked artery, I would get that discomfort on exercise and I would sit down and it will disappear. That discomfort will not occur with a 50 or 60% blocked arteries. So only around when the blockage gets 70% that these anginal symptoms start appearing. Now, when on that 70 or 80% blockage, suddenly a clot gets struck and the sudden stoppage of blood occurs to the heart, almost like a pipe which was narrowed down and there was a block in the pipe and suddenly a kachra got stuck on it and suddenly there was no flow in our pipes and suddenly there was no flow in the tap. Right. And that happens to the heart muscle.
We can't hear you, Dr. Seth. You've been muted. Can you please unmute yourself again?
How did that happen spontaneously?
Sorry, just say that last sentence again. We lost the
So the last sentence related to that when on that 80% blockage, a clot gets stuck, and suddenly the blood flow stops to the heart muscle. The heart muscle starts dying and getting damaged. And over a 12-hour period, the muscle actually damages completely. That's this heart attack. That's when one gets, instead of getting a compression on the chest on exercise, this is now a severe tightness and compression on the chest occurring at rest. Suddenly, it's very severe. It goes down the arm. It's associated with sweating, dizziness, nausea, vomiting. It's almost like a sense of doom. And it's severe constriction, as if there's a brace around the arm. That is the symptom of a heart attack occurring at rest. And the importance of that is that if this is, and occasionally one can have symptoms of indigestion, nausea, vomiting, etc., which are correlated, but the typical symptom is that of severe chest pain. Occurring at rest. And by the way, it's a medical emergency. So angina is a precursor. It's a warning that blockages are developing. Heart attack is when that blockage has actually blocked completely and the blood supply in that particular territory to the heart muscle has stopped.
Right. And cardiac arrest is the end version of it.
Cardiac arrest is a condition in which the heart stops working.
Correct.
Okay. And therefore, that condition commonly can occur because of a heart attack, but also can occur due to many other problems like an anaphylactic shock, like a severe bleed in the brain, like respiratory emergencies, and heart muscle inflammation, all can lead to cardiac arrest. So it's a generalized term for heart getting stopped, and therefore absolutely a cardiac arrest means death if there is no resuscitation over the next few minutes.
Yeah, and there also we have what is like a 3-minute window, right?
Well, you have a few minutes of a window. We won't say 3, but yes, by 5 minutes, the brain stops functioning. By 5 to 7 minutes, gets irreversibly damaged, and you have just a few minutes, and therefore by 7 to 10 minutes, you cannot bring the patient back to life. So I think these are the important aspects. Do not confuse heart attack with cardiac arrest. Cardiac arrest means death if not resuscitated in a few minutes. Heart attack is a medical emergency which requires treatment.
Right. Okay, thank you so much. See, all those terms, I think it's a very important thing to clarify upfront, because a lot of times we use a lot of things interchangeably and unknowingly.
Correct.
So I think and
I hope that the perspective is there that many of the cardiac arrests are due to heart attack because it's an important cause of cardiac arrest.
Absolutely.
But not the sole cause.
No, and I'm glad you mentioned that, because often at times we don't understand that there are other factors that can cause that. So now, while we're on this understanding the role of and the different types of heart disease, one of the things that repeatedly pops up is the role of cholesterol. So I've got a rapid fire a few questions for you on cholesterol before I take you to the next category. How do cholesterol levels affect a heart? And is high cholesterol concerning? Because we keep hearing about, it's okay, this is not okay, HDL, LDL, triglycerides, what is acceptable ratio? What is the range of a red flag? So now I'm just going to hand it over to you to share your perspective.
I think I'm going to put it into a different perspective. That's too specific a question.
Okay.
Because heart disease and blockages, and let's call it coronary artery disease for understanding, because you really yourself clarified to everybody right in the beginning that heart disease is a very large and vague term which encompasses 80 different or 100 different forms of disorders.
Lots of things. Okay.
But coronary artery disease is the blockages in the arteries of the heart, with which we are most concerned about, because that's the one which is the biggest killer. So when we talk about that, and by the way, I just wanted to clarify at this time that you talked about stroke.
Yes.
And stroke, by the way, is a term used for the brain. That's when the arteries of the brain get the blockages, and because of a clot again getting stuck in the arteries of the brain, one gets paralysis or hemiplegia, as we call it, when paralysis occurs, and that's the stroke. It can also result in bleeding in the brain, which is called hemorrhage, and that also causes stroke. Causes stroke. Yes, it is a disorder which is linked to the same, same blockages and plaques, and has the same risk factors as heart disease. And that's why it's grouped as heart disease, strokes. And peripheral vascular disease, because all that relates to the common risk factors of diabetes, hypertension, smoking, etc. So let's get down to what you asked me about, and that was regarding coronary artery disease, and also regarding lipids. Now, I said it's multifactorial, and let's just define the important risk factors so that it's a reminder to every one of us. Of course, we say that there's a family history of heart disease, which is very important. On top of that, let me just say that Indians are genetically predisposed to having heart disease in a huge way. Whether it's genetics or whether just because we have larger risk factors than anybody else in the world. As you know, we're the diabetes capital of the world, we're the hypertension capital of the world. So if I had to put clearly the risk factors, which we always worried about, one is the family. No, before that, let me just put the perspective that we are 3 times more predisposed than Americans or the white Caucasians to have heart attacks. We're 6 times more prone than Chinese and 20 times more prone than Japanese to have heart attacks. We are, as in India, the heart attack capital of the world. 50% of deaths from heart disease across the world happen from India. We have 17 lakh deaths happening from heart disease. And heart disease, by the way, is growing exponentially over the last 20 years, more so in young individuals, where our 25% of the deaths from heart attacks occur at the age less than 40, and 50% of the heart attacks are occurring at the age less than 55 to 60. We are inundated. So we are actually looking at a situation which is growing rapidly worse, especially when we consider that we are a country where more than 50% of the population is youth.
Youth, absolutely.
Less than 30. And therefore, we are even more concerned that as age goes on, coronary artery disease and heart attacks are going to be an continuing increasing trend in India. I also want to emphasize that women have equal risk of heart disease as men, in the sense of the fact that even in women, it is the biggest cause of death. It's already known as the biggest cause of death in men. Now it is the biggest cause of death in women. It is 6 times commoner than breast cancer as a cause of death in women.
Wow.
And earlier, as we used to think that women are more protected towards heart disease compared to men, that has been dispelled also over the last 10 to 15 years. The age at which it's striking women is gradually decreasing, and therefore we're concerned and focusing on women also, very importantly, to protect themselves from heart disease. Earlier, if you recall, it was just the men. In fact, most of the studies were done on men. Yes. In fact, it was a men's disease rather than
a woman's. Absolutely, yeah.
So having said it's multifactorial, I was just going to emphasize that family history, very important. Smoking, extremely high risk factor. Diabetes and hypertension. As you know, India is the world capital of diabetes. 25% people have hypertension, and adults have hypertension.
Yeah.
Obesity, which also includes the fact that lipids is high lipids, and we'll come to the lipid question. And then stress. Now you put all these together, we have the major risk factors for developing heart disease. And then we come to the isolated risk factor you talked about. You say, okay, so what about lipids? Clearly, high cholesterol, especially LDL cholesterol, and that is the one to watch for. We call that the bad cholesterol. And there is the HDL cholesterol, which is the good cholesterol. LDL cholesterol has clearly been linked to blockages in the arteries of the heart. And it is clear distinction that decreasing that LDL cholesterol can decrease the blockages in the arteries of the heart. So we have to understand that as a risk factor. We can discuss what sort of levels are we talking about, but Indians have a preponderance for a different type of lipid abnormality. We call that the syndrome XX. It's a combination of raised triglycerides and not the LDL cholesterols. Raised triglycerides, low HDL, which means low good cholesterol, high triglycerides, central obesities, and glucose intolerance. Once we have that, this itself becomes another risk factor for developing coronary artery disease. So I don't want to go into confusing people, but just remember for yourself, triglycerides, LDL cholesterol, and HDL cholesterol are the ones we're looking at when we check people out.
Okay, wonderful. So, you talked about role of family history. I know you've covered a lot of things, but I'm just going to dive into a couple of the things that you raised. So the role of family history, and you said everybody, that we are more predisposed to it, India as a nation. But what exactly defines family history? Because a lot of us, if you have an 80-year-old parent who has it versus a 50-year-old parent who has it. So can you, for the audience, can you tell us what defines it really?
Yes. Bhavna, I think I will then request this conversation to go briefly into each of these risk factors because it's important for people.
Absolutely.
And you asked the right question. What's a family history? Family history is a very important risk factor. And let me just say why a family, what we mean by family history.
Yeah.
If any of the parents, which means father or mother, have had a heart disease, diagnosed heart disease, or heart attack, or any of the heart treatment procedures like bypass surgery or angioplasty, or has had a sudden cardiac death before the age of 60, we say that's a family history. The younger that age gets, the worse the preponderance for the children to have it gets. So if there's a family in which one of the parents had a sudden cardiac death or a death from a heart attack by the age of 40, gosh, that becomes very important for a checkup to happen in the children of such a parent.
Right.
And by the way, the unfortunate aspect of all this is, it's not just important risk factor for men, but it's also for ladies. Yeah. We have seen even 33-year-old ladies and 35-year-old young ladies developing heart disease without any risk factors, the only risk factor being early heart disease and heart attack in one of the parents.
Right.
And that is quite surprising. The other aspect I want everybody to understand is that given that family history, which we can't change for ourselves, I mean, we were born to that parent, so we can't change. But if I just add smoking to it, and I say, क्या कर रहा हूँ? मैं तो रोज एक्सरसाइज करता हूँ, मैं तो भागता हूँ. I actually am a fitness fanatic. मैं तो सही चीजें खाता. Look at me, I'm so slim. I go to the gym. मेरा क्या है? मैं तो 5-7 सिगरेट ही पीता हूँ दोस्तों के साथ बैठ के. By the way, that's increasing, irrespective of everything that I'm saying कि मैं अच्छा खाता हूँ और मैं एक्सरसाइज करता हूँ and I'm slim. It has actually increased my risk factor by 9 times for having heart attacks.
Just by smoking 5 to 7 cigarettes.
With a family history, which had already which had already increased it by 3 times, and then I've increased it by 9 times. But if I actually just add on कि मेरे को थोड़ा blood pressure हो गया और मैंने blood pressure check कराया और वो high निकला मगर मैं उसको treat नहीं करा रहा हूँ, and I say but मेरे को तो कुछ है ही नहीं, मैं तो ऐसे है कि मैं तो 10 किलोमीटर रोज भागता हूँ. That increases the chances of my multiplies it to 20 times of my developing heart attacks. So it's a multiplication factor. So जो हम कहते हैं ना कि हम बड़े अच्छी lifestyle lead कर रहे हैं, we got to define our risk factors and say, am I actually got all my risk factors controlled, or am I destroying some of the good things I do with some of the known bad things that are already existent? And that's why I say the things you can't change, you have no control over. That's your family history. The fact, if I'm a male and I've got a greater preponderance, I can't change that. But what I can change is our modifiable risk factors, good control of diabetes, good control of cholesterol, not to smoke, have blood pressure under control, not be overweight, exercise regularly, eat the right things. And then, by the way, this is not a complex recipe. It's what we call healthy living at the end.
It's just healthy lifestyle.
A healthy lifestyle.
No, absolutely. So, okay, so to clarify, if somebody is under 60 and then they suffer it, only then you classify them as having a family history. Otherwise, it's just normal aging.
Correct.
So, but Doc, you just
said right. Normal aging, I just want to call it correctly. Just like we gray our hair, just like we have arthritis, just like I develop any other aging, skin creases or whatever. Our arteries also age and will develop blockages with age as it goes.
Okay, fantastic. You just touched upon, women have it and men have it, but you touched upon something that we're seeing, and this is, let's not talk with COVID, but there just seems to be a whole host of people who are younger, especially, in this 45 to 55 male age group. What is going on with them? Like why is that group unique almost, or higher susceptibility to a heart attack?
And now there are 2 aspects, and let me just dwell on the 2 aspects. One is heart disease in the young group without the COVID, and the second one is COVID. I think both are important to talk about.
Yeah, we'll touch on both.
Okay.
Yeah.
So one is yes, we see heart disease at a younger age. I expressed that earlier. In the last 15 years, heart disease in younger age group, less than 45, has grown 3 times. 3 times.
Right.
Heart attacks have increased by 3 times. And that we believe is due to the changing lifestyle of a whole lifestyle has changed. So in terms of diets, the lifestyle has changed. Fast foods have come in, off-the-shelf foods have come in, eating out has come in, and it's all related to trans fats. A lot of people come and ask me,
Processed food.
I said, ghar ka khana khao, wo to acha banta hai, that's in healthy oils, that's cooked well. There's nothing you should stop eating and not stop eating. Bahar ka khana kam khao, because it's to do with trans fats. It's not got to do with fat. Even ghee is okay for you, but what is not okay is trans fat. So bahar ka khana, less of exercise, obesity. Exercise has gone down hugely, and if people exercise, they exercise our youngsters, and I can't blame them. Gymming is not bad. One's physique is good. You have to maintain physique, and I say that for men and women. And I actually say that for all, that it's good to do gymming and physique and how you look, and you got to look slim and you got to be muscular. What gets bad is that cannot just be equated to heart health, unfortunately. And so that's the other aspect I wanted to say.
No, being fit cannot be, being physically fit like in a gymming person does not equal good heart health.
Heart health, absolutely.
Yes, that's the clarification. So you may be fit, you may be able to run 10 kilometers. However, that does not mean you have good heart health.
And I think I should just expand on that more. It's been actually shown, and along with gymming comes in fad diets, also comes in, extreme diets. Fad diets. Extreme type of diets and supplements, many of which are harmful.
Yeah.
And unfortunately, therefore, physique may look good, but we may be harming ourselves inside. So we must keep that actually in mind. Having said that, we know that heart disease is on the increase in the young, and then there is also the stress. Stress levels have changed immensely because deadlines have to be met. There are irregular working hours, there are longer working hours. Expectations have gone up, both for ourselves, from the individuals themselves, and both from the environment, where the expectations and competitions gone up. So we've actually got bad diet, we've got obesity, we've got stress, we've got increased smoking, and we've got all the milieu of increased risk factors for the young. Exercise part is very important. If I was to just give you an example and say, exercise is one of the best ways to decrease the chances of heart attack by 25%, more than anybody else. But all that means is 150 to 200 minutes of brisk walking a week. What does that translate into? 30 to 40 minutes of brisk walking 5 times a week. That's what it translates into. And if one does that, one's decreased the chances. That's heart health. Those are aerobic exercises, not anaerobic. They're not to do with weightlifting. They're to do with swimming,
cardio, what
walking,
we call,
cycling, all those. And by the way, on practical terms, if I was to tell you, the speed at which you walk to assess whether you're actually walking at the right speed for your heart health is that if you can speak a sentence while walking, then you're walking at the right pace. If you can have a conversation with a colleague while walking, you're walking slowly. And if you can't even say 2 words or 3 words in a single go, you're walking too fast. Now that decreases the risk of heart attack. But on the other hand, I may say, मैं तो 10 kilometers भागता हूँ. It's increasing my stamina. I may be able to lose weight. I will feel better. But that does not necessarily mean I'm improving my heart health. That can be achieved by just aerobic exercises of total of 40 minutes a day, 5 times a week. Okay, now coming to the COVID issue. So the COVID issue, COVID and heart. And those unfortunate incidents.
Can I read one thing to you? Harvard Medical School published a study which says in the week after a COVID-19 diagnosis, the risk of a first heart attack increased by 3 to 8 times. The risk of a first stroke caused by a blood clot multiplied by 3 to 6 times.
Absolutely.
In the following weeks, both risks decreased steadily but stayed elevated for at least a month.
Correct.
Now, other bacterial and viral infections also temporarily boost the rates of heart attacks and strokes, but COVID-19 appears to be especially risky because, as you said, exaggerated inflammatory response that makes blood clots more likely. So here
it's very important now. So we're coming to the COVID aspect of it.
Yeah.
And we've actually, and I'm not sure whether we've analyzed and understood everything about COVID by this time, despite the 2 years. And you can see that yourself, that every day, I mean, when we thought we've sussed it all out and the Delta wave struck us, and that was suddenly, it was another variant on us, which we weren't even prepared for.
Yeah.
Even after a year of all the world's brain put together. And just when we thought that now this could be the end and we've got these vaccines and we would be over it all, suddenly comes the Omicron.
Yeah.
So we're always behind the virus rather than ahead of the virus. And this is one of those aspects that we realized that during recovery. See, COVID is a virus which is as much a heart disease as a lung disease. And I wrote this up even in the opinion in Hindustan Times soon after the first wave in May of 2020. In the opinion column saying it's not just a heart disease, it's not just a lung disease, it's a heart disease.
Yes.
Because the virus affects the heart in 3 ways. It causes increased clotting of the blood.
Yeah.
And therefore the arteries of the heart can develop clots causing heart attacks. The arteries to the brain, even in young people, can have clots causing strokes, and in the lungs causes pulmonary embolism. And not just that presents acutely as a part of COVID, that can actually be prolonged, not just for even 4 weeks, can be prolonged for up to 3 months. So that's the biggest concern for us. The second aspect is the inflammation directly to the muscle of the heart.
Yes.
What we call myocarditis.
Yes.
It starts creating inflammation, which causes weakening of the heart muscle. And that heart muscle can actually weaken to heart failure over the next few weeks' time. And though this is linked to severe COVID, if people are, through my talks, are trying to correlate to any of them or their relatives, please don't. It's for your understanding, but don't try to just correlate it, because by this time, loads and possibly many, even in your audience, would either have had COVID or would have had relatives or close friends who had COVID. And I also have had COVID, and then my family's had COVID. So that's now not an unusual. But if it is moderate to severe COVID, the heart gets more affected. But even in the mild cases, it does get affected. And then even after recovery, that heart is still inflamed. And the third aspect is that it also affects the conduction system of the heart and causes very fast heart rates or very slow heart rate. So what does this transfer into? Soon after recovery, the heart, we may have recovered from the symptoms, which means we may have recovered from the breathing problem, we may have fever has come down. We have recovered from the illness, but we have not recovered from the virus effects on us. The virus can be found even in our brain of those severely affected months down the road. That's been seen. The inflammation has still not settled in our heart. Will take weeks to settle. And what does that do, therefore? If we so firstly, we still increase at a risk, or some of us would be at increased risk of clotting. Many of us could be at increased risk of heart rate going suddenly very high, or even becoming dangerous levels if we exercise too much. And therefore, we have those arrhythmias and the myocarditis, or we may develop weakening of the heart muscle as we go along. So the recovery from COVID is as equally important for us as the COVID itself. And we always advise those who recover from COVID not to get back to exercise. हमारे पास आता है ना कि मैं तो पहले बहुत exercise करता था. I used to be gymming. I was actually jogging. मैं तो 4 marathon कर चुका हूँ इस साल. And they would be willing to get back to that marathon, saying मैं 10 किलोमीटर कब भाग सकता हूँ? अगले हफ्ते तो मेरे को तो लग रहा है मैं भाग सकता हूँ. We would actually have to tell them they could get back to it over a 3-month period. So we say no severe exercise for a month. Graduated recovery thereafter to your previous levels of exercise over a period of 2 to 3 months. That is so important to make sure that the inflammatory process of the heart has settled before, so that we don't have heart attacks. I'm not saying everybody's going to have it, but yes, there is an increased incidence of it.
Absolutely.
And therefore, that is why the precautions have to be taken, not to rapidly get back to exercise of severe strenuous exercise during recovery from COVID.
Sure. Can I just ask you one thing since we're on the topic of exercise here? Because you mentioned cardio exercise, walking at that pace. So that kind of exercise is fine. But
it's fine.
But not the gymming, not like, high intensity.
Yeah. And even that exercise, which I say brisk walking, needs to be got after a month, because before that, it is lesser speed of walking. Brisk walking on an average for all of us would come at 6 kilometers an hour.
Right.
For most of us, then we would say walk at 3 to 4 kilometers an hour, which is a casual, comfortable pace for 25 minutes, 30 minutes, 35 minutes, build up yourself. It's only after a month that you start the brisker walking. And certainly the severe exercise people are used to, people may have been doing before, extreme sports people may have been doing before, only come late, 3 months to 6 months later.
Okay. Wonderful. On the topic of myocarditis, I just want to ask you, because the signs and symptoms to a heart attack are very similar: chest pain, fatigue, shortness of breath, rapid, irregular heartbeats. So how does one differentiate between myocarditis and a heart attack, especially if the symptoms are very similar?
So Bhavna, we see our message to people is not to do these diagnoses themselves. A heart pain is a heart pain. And so our clarity is that whether you have had COVID or not had COVID, but let's continue in the relevance of COVID as you said.
Absolutely. Yeah.
Is that if you, during recovery, feel palpitations, feel breathlessness, have chest pain, have dizziness, during exercise or even at rest, do see a doctor. That is what we actually can do. Because it's for the doctor to differentiate. And by the way, even for doctors to differentiate whether it's myocarditis or a heart attack may take 24 hours, because not just are the symptoms similar, ECG can also be very similar. It's only when you look at the arteries by, say, indirect methods, even like CT or an MRI for the heart muscle, is that you're able to differentiate between these.
So are these would you suggest that somebody do these tests? And what do you feel of your thoughts on a CT angio of the heart? Is it essential after what age? Or what would be the reason,
So I think it's a very, very important question. I think you've asked one of the most pertinent issues, which at the moment people are confused with. Should we get CT? I don't think everybody needs a CT, to tell you frankly.
Right.
And neither can everybody afford a CT. And I think it's an unnecessary use of investigation, which also has radiation inbuilt into it.
Yeah, absolutely.
But what is very important to understand is that those with risk factors, especially those with a strong family history, must get evaluation done. When we say evaluation, the reason I would say most young people will need a checkup. And a checkup, I say, people should have. In fact, this country needs more checkups. But by the checkup, I don't mean exhaustive investigation. No. What I mean is that there are 3 things that cannot be picked up by your own self. Hypertension is a silent killer.
Yes.
And it is increasing. Diabetes is a silent killer. It doesn't get picked up for quite some times and months. And so that's the second aspect. And cholesterols are silent killers. Now, those get only picked up on checkups. So when I talk about checkups, I don't mean that you should be having exercise tests and CT scans and everything. I do mean that a visit even to your local practitioner, occasionally, even at a young age, to get your blood pressure checked, to make sure that you have not got diabetes for any reason just because it occurred in the family as well. And you make sure your cholesterol, at least for men, early on in life are important. Now, this is for all. This is for all.
Yeah.
Okay, but those who are at risk factors, which means father or mother or brothers or sisters at a young age have had a heart problem.
Yeah.
There's an inbuilt family history. And then I also have diabetes on top of that.
Yeah.
I need a checkup.
There are layers because you've got all the risk factors.
That's right. Then I've got 9 times the risk. Then I go through a proper checkup. Maybe at that stage, or I'm a smoker. And at that stage, I may be saying I eat everything right. I've got a family history. I'm a smoker.
Yeah.
My cholesterol levels are going to be directed by what I have. And if I then decide that, look, I've not been exercising, now I want to get on to extreme sports, or I want to actually now be a marathon runner, and therefore I'm going to train to do that, then I certainly going to need a checkup, which is far more important than just saying, let's just have the blood test done. That's the stage I may need a CT scan. That's the stage I may need an exercise test or a better test or a thallium test to make sure that I'm not developing occult blockages, which during severe exercise can suddenly create a severe strain on the heart and create heart attacks. So one of the causes, by the way, everybody should know is that heart attacks occur in the young. Yes. Because of even not those 90 and 80% blockages. You remember we all say, or मेरी तो 90% blockages निकली, मेरा क्या होगा? Or I say, somebody says, मेरी तो तीनों arteries पूरी blocked थी. That's why I was advised surgery. So our common thought process is, the more severe the blockage, the greater the risk of the heart attack. But that's not the case for the young. They can have heart attacks. Young can have heart attacks even with a 40% blockage or a 50% blockage, which hasn't even caused any symptoms, with which they can exercise and bicycle for 40 minutes and still not feel the discomfort. But during severe extreme exercise or with smoking, clots can develop on the arteries of the heart, and suddenly a major heart attack can come. And some of those major heart attacks turn into sudden cardiac arrest and sudden death. So that is the reason why we are more scared of making sure that those with risk factors do get some form of a check. And those taking severe unaccustomed exercise, be very cautious about it and graduate themselves into exercise. Or those going for extreme sports should have checkups. And by the way, there are some congenital disorders and anomalies which also cause sudden cardiac death during exercise. That's why you see the occasional, we keep asking these questions ourselves all the time. There was this football player who suddenly was playing the ball, the whole world's watching that football match, and suddenly he actually dies or practically gets resuscitated on the turf by paramedics. Otherwise he would have died. Well, those are congenital heart disease conditions which led to that. He didn't have a heart attack. Those 20-year-olds and 17-year-olds and 25-year-olds in extreme sports get due to congenital heart conditions, but come to the 35 and 40-year and 45, the attacks coronary artery disease. Okay, wonderful. So one thing that you, and by the way, one more thing, we because, and again, I'm speaking to my your whole a group of very intelligent people who are in the midst of their prime life amongst the CII. But unfortunately, what happens to all of us is that something like this happens to a close friend of ours, somebody we know, somebody who we've seen, somebody we've heard of, or somebody, and it automatically impacts us, saying, mere ko bhi ho sakta hai, ya mere ko bhi hai, or we start speculating as to what could have happened. And by the way, when we sit around here, we're not speculating about any individual or anything. We're just talking in general. Saying that we should not ourselves put into any of those issues because we don't understand what was the reason specifically of something to have happened to someone else. It's almost like to a specific. So we should only look at what relates to us in terms of the risk factors and what sort of checks do we need. But we shouldn't always think that usne to make, it's almost like thinking ki somebody went to a car showroom and bought X make of a car, and as he drove out, the car actually stopped or had an accident. Then you think, us make ki to car leni nahi chahiye. वो तो accident, वो तो car निकलती है तो accident हो जाता है. It's not that way. Yeah, Saturday को car नहीं लेनी चाहिए because accident हो जाता है. No, so certain factors does not mean that there's absolute resonance for you. Correct. I think that's a very valid point, and nor should it should not put fear into the hearts of people. Into the fear. Somebody you know. So I think that's a very valid point. But Doc, I just want you to make that point one more time, that this young audience that is getting it, that was a very important part that you said. It doesn't mean 80-90% blockage. It means that even with 30-40% blockage at a point in time,
you could be susceptible to this.
Correct.
Because of that intense pressure that goes on the heart at a point in time through extreme exercise.
I think you even put my words much more simpler than I put them. Yes, you're right. Intense pressure on those blockages, it makes them rupture. The blockages suddenly burst open because there's intense pressure. The heart rate's gone up, the catecholamines gone up. Increased coagulation of blood happens with increased catecholamine. So body builds up a milieu of precipitating clot formation. Smokers, even worse, they are anyway predisposed to clot formation. So a smoker exercising extremely, gosh, it always worries me that suddenly that person's going to have a heart attack, and some of those heart attacks can be, sudden arrest. So yes, those are the reasons why we say regular checkups. But by the way, in the layers of checkup, blood tests for all very early in life, layering goes to more sophisticated tests like exercise tests and exercise scans for those taking up severe exercise, and those with real risk factors of sudden cardiac deaths and heart attacks very early in their life, in their families, and with other risk factors themselves like hypertension, diabetes, etc. Will actually need a CT scan early in life, CT angiograms early in life, so that proper therapy of risk factor control can be instituted. You ask about cholesterol. We don't look at cholesterols by numbers, and many people come to me saying, "No, cholesterol to mera theek hai." So I say, "What do you mean by theek?" Uske some numbers अच्छे थे. So I said, "How do you know numbers अच्छे थे?" कहते जी उसमें लिखा था range, and I said, the reason that range doesn't matter is that range matters for a normal public who have no risk factors. But agar diabetes hai, तो our range of LDL cholesterol for that diabetic patient it should lie between 70 and 100. And if it's a young diabetic, we'd say कि 70 se niche la cholesterol. Because it relates, if there's a family history for me, that number goes down to not 100 to 120, but it goes down to 70 to 100. So what we know as target levels becomes very important. ये जो एक और बात, भावना इस time पे, I think I need to dispel people's doubt about statins.
Yes, it's my next question. You're a mind reader. Please go ahead. I was going to ask you aspirin and statins. What are your thoughts on that? I bet you अभी काफी सारे questions होंगे आपके उसमें. इनसे पूछो statins. Yeah, we'll get there.
So you see, and that's unfortunately the WhatsApppedia.
WhatsApp University. That's why we launched Need of the Hour. Because we said we want to get away from it. Yeah.
So the statins have been overprescribed. The reason for the overprescription is कि अगर किसी को risk factor नहीं है, then he does not need to be on statins. If he's got no risk factors for having heart disease, and unfortunately, the Western prescriptions relied on primary prevention, which means the risk factors nahi hai. You can't dish it out into a population just like it's water or just like it's salt. That's the whole issue, and that's the overprescription issue. But once we have the risk factors for heart disease or are known to have heart disease, that means blockages have been picked up, early blockages have been picked up, or we've had heart attacks. There is no question, we call that secondary prevention. There is absolutely no question worldwide with every scientific data and no ambiguity, and it's a consensus issue. That statins are the biggest saviors in decreasing cholesterols, and especially bad cholesterol, will improve our outcomes, decrease heart attacks, and decrease progress of blockages. So if if I turn out with a blockage of 30-40% on a CT, I will start taking statins, even though I'm asymptomatic, because that's one drug which has been known to keep it at 40 and will prevent it from progressing or having a heart attack in the years to come. So people out there, please understand, if there's been a diagnosis of heart disease, diagnosis of blockage, if you're diabetic, if you've got risk factors, then the LDL levels have to be below a certain range, and statins are helpful. If you've got no risk factors, then the LDL cholesterol levels can vary between 100 to 130, and then you can actually be not on statins. The only reason we'll have people on statins in that group is if the LDL cholesterols are beyond 170 to 180. By the way, that's Western recommendations. For us, because we are multifactorial, we can have high triglycerides, low HDL cholesterol, we would need to put people on statins, but we are dead against everybody taking statins just because a bit of LDL cholesterol was high. For us, it has to be hugely high to take statins, unless they had a diagnosed heart disease.
Sure. Okay, Doc. So
I hope Bhavna that clarified it for people, and if people haven't understood
well,
I'm sure they have.
Aspirin. Let's talk about aspirin for a quick second.
Mm.
Everybody wants to take it. Everybody just wants to take it. Like, let's just take, 0.75 every day.
75 milligrams of aspirin.
Yeah.
Remember, those with heart disease and heart attacks, but it is not a drug for the reason.
Doc, you're breaking up. It's not a drug for, say that again. Is Dr. Seth frozen, or am I the one frozen?
Dr. Seth.
Bhavna, Dr. Seth has, I think, some internet issue.
Yeah, I think let's just give him a minute to maybe,
Let's give him a minute. Kanchan, he
Bhavna,
hasn't given me a response yet on the aspirin. Sorry, thank you.
Can you just call him?
Yeah.
Okay.
Sure, Bhavna. Yeah, perfect. This is a fantastic conversation with Dr. Seth, and answering some of our good questions here. He's back. Wonderful.
So yes, I was just saying that I saw that my connection was unstable. Yeah, and aspirin.
Yes, please.
So aspirin is a drug which causes bleeding risk. It is the commonest cause of gastric ulcers and bleeding from the stomach.
Yeah.
It's a blood thinner and therefore causes bleeding in the brain and other places. On the other hand, it prevents heart attacks.
Right.
So therefore, it's quite obvious that what we got to do is weigh the bleeding risk versus the risk of prevention of heart attacks and clots in the brain. So it should not be given without a reason. That's the first thing. Not everybody should be having it.
So fear should not drive the usage of aspirin.
No, absolutely, because it has its side effects as well.
Correct.
And the side effects are bleeding. The third aspect is that those with diagnosed heart disease, it is an absolute must to take aspirin. It does prevent heart attacks. But for those with diabetes and those with hypertension, it's an absolute no unless it's diagnosed with heart disease. Because in hypertension, it could actually be creating a risk in blood pressure. In people with high blood pressure, it can cause bleeding in the brain. So no unnecessary prescription or intake of aspirin at all. It should be prescribed by the doctor, and it has its own bleeding risks. And by the way, in the elderly, as the age goes on, we understand that our bleeding risk continues to rise. Our preponderance for ulcers, bleeding risk in the brain, bleeding risk from a fall, all continue to rise. And therefore, prescription in the elderly beyond the age of 75 and 80 has to be truly thought out thoroughly for giving aspirin, even for prevention of heart attacks, weighing that we may be actually increasing the bleeding risk, and the heart attack risk may not be so lowered and the bleeding risk may overpower. So beyond a particular point, we have to do. But those with stents, by the way, those who've had stents, cannot stop taking aspirin for the whole of their lives. So that's again very important observation.
Okay, wonderful.
They should not stop aspirin. But by the way, it's Bhavna, your next question. Let me just say that. So why aspirin and heart attack?
Yes.
let's people do have this worry, concern about heart attack, and then they said you yourself mentioned at some stage that what are the drugs for the heart? Do you have that written down or not?
Yes, I do. It's
you
coming.
Want to address that now because I don't know even.
Go
I
right
haven't looked
ahead,
at the
Doc,
time.
please.
I haven't looked at the time.
And then we have to hit audience questions, but I'm just going to let you speak for a few minutes, and I have to.
Okay. So you raised aspirin issue. You raised the aspirin issue.
Go ahead.
I would say to everybody that have the Disprin, which is the soluble aspirin,
Yeah.
325 milligrams available to you at all times.
Okay.
It is the fastest acting aspirin. You can just chew it. You can dissolve it in water, drink it, but chew it. When I say chew, it means if at any stage anybody in the home started having a heart attack, or you were at a situation where somebody had a heart attack, or aspirin was needed. Aspirin is the most wonder drug for a heart attack. That's the only drug which can actually be taken at home. It's the only treatment which can actually be taken at home for a heart attack.
Yeah, so this is the one at that critical time. At that critical time for yourself or a loved one.
Before getting to the hospital. Before getting to the hospital.
If somebody is displaying any symptoms of a heart attack.
That's right. Of a heart attack, and you're in an office and you see a friend, do you think is going to be rushed to hospital? Give him an aspirin. So aspirin is something that, and that's the dissolvable aspirin, because that works fastest. It's not the enteric-coated aspirin, which you call Ecosprin, because that takes time to work.
Yes. So this is the drug that everybody should keep at home. So which can save one's life during a sudden heart attack. For yourself or somebody else that you think was possibly could be having a heart attack, then or they start manifesting any symptoms, this Disprin that you're talking about. Would you just repeat that? What is the milligramage? And it has to be water soluble.
It's a 325 milligram tablet. One tablet crushed or chewed straight away.
Yeah, thank you, Dr. Glassi, for writing that.
It's absolutely over-the-counter medication.
Okay. Doc, I'm just going to come to kids for a quick minute, for 2-3 minutes, and then we're going to take our audience questions. Are the variants causing health problems or heart problems in children? The COVID variants, Delta, Omicron, are they causing any heart problems in children?
Okay. Yeah, the children are less susceptible, by the way, to all the complications of COVID. That has been clearly seen. But yes, inflammation has actually been seen. Every complication of COVID has also occurred in children. And by the way, inflammatory reactions of the muscle and myocarditis has happened in children. So I think all we can say at the moment is that with every virus, whatever the variant is, and by the way, many other viruses like the flu, Coxsackie, other viruses cause the myocarditis, cause the inflammation of the heart muscle. And it also happens in children. So for us, it's not the number issue, and it's not likely or more likely. It has similar effects, but luckily, children are less susceptible to the complications of COVID.
Okay. There's a fear that the mRNA vaccines are causing inflammation in the heart for children, especially boys.
Yes,
what are your thoughts on
that's
that?
Right. So we don't have mRNA vaccines here at the moment, so we're not so concerned about it. But yes, those were reports out in the West. And certainly a number of people did ask me whose children were based, whose children or their children or grandchildren were based in the United States about it. There were concerns regarding that clearly, but we must remember that that was a minuscule proportion of the vast amounts of vaccines which have actually been given. So in a way, I would say that any of the side effects of vaccines, whether it is Covishield and whether it's the vaccines available to us in India or whether it's vaccines abroad, what is clear is two aspects: that the risks of these vaccines are minuscule compared to its prevention from serious COVID disease and life-threatening complications and death. And it actually stands out so clearly that if I was to tell you that all complications that you've actually heard, right from clotting to death, occur anywhere between 0.4 to 10 in a million.
Yeah.
Which means that's a huge, that's the sort of complication rate we're talking about. And yet we have 500% higher chances, 500 times higher chances of actually catching a COVID and one of its complications.
So your cost benefit analysis, in a way, you just apply it to the vaccine and say,
right. Absolutely.
Okay.
So that's
Doc, we're going to take our questions. I want to ask you, the last one is, how do we optimize our heart health? And what are the 5 things that we can do to keep our heart healthy and in check? So would you like to give us your top 5 tips for prevention?
So the top type, yes, I can. for me, the first, of course, is smoking. An absolute no, no, no. And not just would I say smoking, an absolute no, no. I would say that even sitting with a smoker is an absolute no.
Secondhand smoke, yeah.
Okay, the secondhand smoke is as bad. I mean, it's not as bad, but as bad. That's been shown to actually affect heart disease and create heart disease. So I think that's an absolute no. Now, that is in terms of, and the second part, let me just start I said smoking because that's an absolute no-no, and I have to emphasize that. But the second most important thing, and can put it the first if people are not smokers, to say exercise. That thing I told you, that mantra of exercise, 25% decrease in heart attacks by just exercising 200 minutes a week is practically nothing. It's like 30 to 40 minutes a day. And brisk walking. And that brisk walking can be interspersed in a number of ways. It could be just twice a day. It could be walking from your car to your office multiple times, or it could be in the office going up and down the stairs multiple times. So that is so important because it actually decreases weight, it improves diabetes, it improves hypertension, it improves lipids, it improves sense of well-being, and it does practically everything. So I say it's not in your hands, it's actually in your feet to decrease the risk of heart disease.
Sure.
So that's my second most important mantra. My third important mantra would relate to mental relaxation. Stress has been an increasing aspect of our lives.
Yeah.
And stress had in the past never been quantified because never were people so stressed 20 years ago and 30 years ago. So it became one of the lowest risk factors. But in our present times, believe you me, I think it's actually becoming one of the most important risk factors in the last 15 years.
I heard a 5-year-old say she was stressed. I heard a 5-year-old say she was stressed. I said, really? She says, Mama ko bhi stress hai, mere ko bhi stress hai. I was like, you're 5.
And you know, when I was growing up, etc., there was absolutely neither my parents were stressed. They had a very comfortable. 8 se jate the, 5, 4, 12 baje ghar aa jate the, khana karte sote the, फिर शाम को 6 baje jate the काम पे, 8 baje aa jate. There was never that sort of a stress 30 years ago and 20 years ago. But now so again, we got to find aspects. It's not how a body responds to everything. A body responds to everybody has stress of some sort or the other. It's how we train our body to respond, and that's what I mean by hobbies, by spending time, by giving time to yourself, by taking time out for relaxation, time out for family holidays, having a hobby, enjoying yourself. So I think it's becoming an absolutely increasing important in our lives.
Yes,
more and more to decrease the stress part of it. Fourth, of course, is regular checkups. I've emphasized that. I've actually defined that. I don't have to redefine it, but regular checkups. And finally, I would actually say, importantly, spirituality. Therefore, part of relief of stress, we always say, is your mental frame of mind, your well-being. You're actually decreasing, you're saying, jo hona tha upar wale ke haath mein. I mean, there is a spirituality angle even to, by the way, to yoga. Yoga is not just the 5 postures that we do and say yoga ho gaya. Yoga inculcates into it is the spirituality, the bit of giving to, whether it's God, whether it's your belief, whether it's something, but it's something more than what human beings can actually achieve. Saying, when you do that, you actually build for yourself an atmosphere which relaxes you, and where the troubles of the life don't get put on somebody else. You don't start finding, you don't finding a reason for everything which bothers you. So actually spirituality helps a lot. And if we put these 5 things together, we have a recipe for decreasing heart attacks and improving heart health in a way, I would say.
Absolutely. That was wonderful, Doc. Thank you so much, Dr. Seth. We're opening now to audience questions. Thank you so much. I loved it, by the way. Okay, the first question up is from Gautam. Do the COVID vaccines affect the heart? That's the first question. And the second, after recovering from COVID, should I avoid exercise that can stress the heart? I think the second one he's already answered, Gautam. The first one, please go ahead.
Yes. Yeah. So the first one is they can really affect the heart, but that again, that myocarditis, clot, and so 3 things which heart can be affected is inflammation of the heart muscle, myocarditis as we call it, and the increased clotting. But those actually fall in that 1 in a million to 5 in a million that I talked to you about.
Yeah.
The risk of clotting was 10 in a million to in some instances, as we get to the other age group, up to 30 in a million. So we're talking about extremely rare circumstance, so rare that the risk of COVID and its complications far outweighs. And by the way, by this time across the world has been given to millions and millions across the world. So understanding the statistics around it is quite clear and being documented by most countries. Even by the way, the clotting disorder in India, even though the Western world said it was 10 out of a million, the clotting disorder in India was 0.6 out of a million. So extremely rare.
Okay. We've got from Shagun.
So you should take vaccine. There's no question. Double vaccinate. It decreases risk of severe infection, decreases risk of death, and that's the most important aspect.
Okay, thank you very much. I think that's a great answer for Gautam and for everybody else who's asking this question regarding the whole correlation. From Shagun, what does stenotic lesions in the right coronary artery mean, RCA?
Okay, so Shagun, there are 3 arteries which supply the blood to the heart muscle. One is on the right side, one is in the front, and one is at the back of the heart. Heart, after all, is a circular or oblong structure. A stenotic, we were discussing the blockages. We were talking about these arteries get blocked to a percentage like 50%, 60%. Stenotic means just a narrowing.
Okay.
A narrowing in a blocked artery, in a right artery. A blockage in the right artery is what is called a stenosis in the right artery. Stenotic is the medical term. In a common lay language, it would be a blockage in the right artery supplying the heart.
Thank you for that. From Shivani, do supplements such as red rice yeast help bring down cholesterol instead of statins?
Sorry, say that again.
Do supplements such as red rice or yeast help bring down cholesterol instead of statins?
Oh, no, not instead of statins. I think that's a great diet. Diet with rough veg, green vegetables, there are other forms. Cannot supplement statins. Statins decrease it by immediately, even in the smallest doses, by down as 25% to 30%. That does not get achieved. So we should say that everything supplements each other. Natural methodology, good diet, exercise, losing weight. By the way, let's not forget that. So it just can't be a diet and no losing weight. It has to be a combination. Will drop lipids down to a certain extent. Now that may or may not reach our target levels, and we may then supplement it with statins. So it's not in lieu of statins. These are steps which either have to be layered or done together.
Yeah, they're not either or,
Shivani. One or the other. Either or.
Yeah.
That's the whole issue.
Okay, great. From Aparna, are there any blood tests that I should do post-Omicron? During the Delta strain, doctors were recommending D-dimer and specific heart markers. But post-Omicron, doctors do not recommend these tests. What do you suggest?
So if we were recommending those, and I would say we were randomly recommending those. We have done on certain individuals who had severe infection. Yes, we did. So it was related to the severity of the infection, not randomly at all. And post-discharge, it was only related to those who recovered from severe infections to see when these got corrected over the period of time.
Okay.
I don't think these tests are important. I don't think tests are important. Yes, what is important? And if I was to actually say, if I, for all those, without frightening, that after COVID, I think I've advised at 4 weeks' time an ECG and an echocardiogram to all. The inflammatory markers are not relevant. It is whether those inflammatory markers have affected your heart muscle at all. And that is why it's done on echocardiogram at 4 to 6 weeks to see if the heart's functioning well, and if the ECG is fine, then you're actually good on your way to recovery. And that's what's more relevant rather than looking at markers, because there's nothing you can do about it after all. It's the effect on the heart which is more important than those blood test levels.
So would you recommend that to people who
let's not go through multiple tests. Yes, I would recommend that. And I would recommend that it's sensible to actually get an echo and an ECG somewhere between 1 to 2 months after recovery, so that you know that recovery has happened. In the last wave, incidentally, there were a number of patients who came to us with weakened hearts after COVID infection, which was discovered only much later because they felt breathless and they were far too late. Perhaps introduction of medicines early for preventing heart failure could have helped them. And that's why I just say that that's 2 precautions that I would take. And the third, for those who have palpitations, I may do a 24-hour recording of the heart just to understand what those palpitations were. Because including my relatives, some of them have had increasingly fast heart rates. Lasted for quite some time after COVID and recovery into COVID, which were of concern. And therefore, then we say, don't exercise too much, because even small amount of exercise raises the heart rate a lot. See, there's still a lot more to understand about COVID. And we're seeing various fluctuations of blood pressure, various fluctuations of heart rate. We're seeing all sorts of abnormalities coming. So yes, it's a good precaution for these 3 simple tests to be done and a doctor to be actually seeing you at least 3 to 4 weeks after COVID.
Okay, great. Can I just ask you one question as a follow-up to this? Is there a certain age group, above a certain age group, that you would recommend this for? So like say under 30s?
Yeah, the elderlies are more prone. The ones who have moderate to severe infection are more prone.
So, age group, and if you had
moderate and severe infection.
Right, okay.
And you have pre-existing heart disease.
Correct.
Existing heart disease.
Okay, fine. Thank you so much. From Arvind.
But then there'll be, but Bhavna, there's all that group who also wants to exercise, get back to normal, who wants to do more vigorous exercises. They want to get to cycling 30 kilometers a day. Yes, those are another group. They should actually get a checkup. Those who want to get back to gymming, who want to get back to gymming, so on and so forth. There we are.
Absolutely. Okay, great. Thank you, Dr. Seth. From Arvind, is olive oil a better oil for cooking as regards with coronary heart disease?
Olive oil is one of the good oils for cooking. There's no question around that. But so is mustard oil. So let's not go for fancy Italian imported virgin olive oils of the highest quality and the highest expense. Our home mustard oil, even though it may smell, is actually equally good. So any of the sunflower, corn oils, olive oil, mustard oil is fine. Even a 2 teaspoon ghee is fine. I think once I've clarified the single fact that vanaspatis were bad, and the recooked oils, which is what we have in outside food, the ones with the halwai baith ke usme jalebi talte rehte ya puriya talte rehte bahar mein, which gets cooked throughout the day multiple times. That's what's bad, because that's what's trans fats. Those are the worst form of oils. So in a way, ghar ka healthy khana, cooked in healthy oils is fine, and I'm not so particular about olive versus mustard versus corn oil.
Great. From Rudranj, which medical drugs should be avoided to reduce the risk of heart attack while treating an ICU patient, or any patient going to have any surgery, or a patient having cancer? You want me to repeat that? Again? Yeah.
Yes, please.
Which medical drugs, medicinal drugs, should be avoided to reduce the risk of heart attack while treating an ICU patient, or any patient going to have any surgery, or a patient having cancer?
No, I think this question cannot be answered in this manner, because it's too vast and too vague in terms of any reference whatsoever. Because the number of drugs I could outline for any specific circumstances could be interacting with the other drugs. I think this question should not be answered because it is too general. I mean, I could give you a list of 50 drugs which could be answered, but that's in relationship to very specific circumstances of why they would lead to a heart attack, and also why they would interact with some other drugs which a person may be taking. So I think it would not be relevant unless it was very specific.
Okay. From Shibani, do high LDL counts in parents count as family history of heart disease? At what we discussed the age, right? At what age would that qualify?
High LDL cholesterol does not classify as family history of heart disease. Heart disease specifically means blockages, heart attacks, death, and angioplasty and bypass surgery. Cholesterol does pass down in families, but it still classifies as one of the risk factors, which is raised cholesterol. But there are conditions of familial hypercholesterolemia in which the cholesterol is hugely high and it runs in the family. And that in itself is an extreme high risk factor for developing early coronary artery disease. But the usual high cholesterols, which all of us talk about, where the LDL cholesterols are anywhere between 100 and 160, are not the disease process that we talk about, which runs through family. Those we talk about triglycerides as much as 2,000 and LDL cholesterols as much as going to 500 to 800. So those are specific familial hypercholesterolemias, which are a separate and an important vertical for heart disease.
Okay, great. From Mahavir, a handful of nuts is considered good for the heart. Could we please be specific? Which ones to avoid and which ones to include?
So it's very simple. Walnuts and badam, okay, or almonds are the two good ones.
Okay.
And clearly have certain benefits, but cashew nuts, pistachios, they have a high calorie content.
Okay.
Those are the ones to be avoided.
Okay, great. From Sushmita, how often should we go for a complete heart health checkup? Is it like an annual physical you suggest, or is it,
So let's define it it's not specific to everybody, because like I had separated out, there are people with risk factors, with no risk factors.
Sure.
After the age of, if there are no risk factors, for ladies, for men, I would say every person by the age of 40, even without risk factors, should actually have gone through a checkup, which would have defined the presence of risk factors or not. So actually, blood pressure, diabetes should have been checked up, cholesterol should have been checked up. Those who have risk factors, remember, in women, the age is 10 years further than men in terms of age for developing coronary artery disease. So for men who have risk factors, who have a family history of heart disease, sudden cardiac, their checkup should start by the age of 20. Even 15, defining lipid profile, sudden cardiac death at the age of 45, one of the parents passed away. By the age of 15, lipid profile should have been defined. From the age of 20, checks should start. By the age of 25 to 30, they could even have a CT angiogram to define the coronary arteries if they had a second risk factor like raised cholesterol and a family history of sudden cardiac death. And that checkups would then continue every 5 years. By the age of 40, I say every man who's not had even any risk factor should have a checkup. Beyond the age of, and it continues really every 5 years. If there is no risk factors, it should continue every year after the age of 40 if there is a risk factor. By the age of 50, all ladies should have had a checkup for defining the risk factors. Those with risk factors already present, like a family history or anything, the age starts much earlier, by the age of 25 to 30.
Okay, great. Thank you so much, Dr. Seth. From Ankush, is Disprin 325 available over the counter, or would we require a prescription?
It is available over the counter. I shouldn't use the trade name. Actually, that is Disprin, but amongst people, I'm not propagating the drug itself, but it's soluble aspirin. The commonest form available for your convenience is Disprin, and it's effervescent tablet. It can be dissolved, it can be chewed. It's 325 milligrams available over the counter.
Yeah, no, I think that's the key messaging, which is that, get the aspirin, make sure it's dissolvable, and perfect. Okay, from Shivani, Dr. Seth, I'm 48. I've had elevated LDL counts averaging between 130 and 160 for the last 4 years. My triglycerides at 170, hypothyroid for many years. My parents have had high LDL2 since their mid-50s and have been on statins. Should I too be on it? And if yes, what would you suggest at the dosage?
No, I mean, this is obviously a consult amongst a lot of people. So Shivani, where do I send you the bill?
And Doc, I just want to warn you, she's got like 6 more coming. So Shivani, I think you please contact Dr. Seth on your own.
Correct. So there's Shivani's mom there and Shivani's sister there, the next ones. No, Shivani, let me answer that. And I think it's probably, I'm answering you because it has implications on a lot of other people also.
Yeah.
So the fact that your parents had lipids is not your family history, to tell you frankly. I already clarified that. Family history means they have to have a heart disease and early in their life. The one fit, no, you're not going to be on statins. You're going to be on lifestyle modification. Though the ideal level, by the way, for you is somewhere between 100 to 120. That's what would be ideal, provided you have no other risk factors. When I say no other risk factors, you shouldn't be overweight. You shouldn't be diabetic. You actually shouldn't have. You shouldn't be hypertensive. Those important risk factors should not. There should be no family history. You hopefully non-smoker, so on and so forth. Otherwise, what I'm going to tell you is modify your risk factors. Apart from diabetes, where I would definitely put you on statins, definitely, because for diabetics, we want your LDL cholesterol to be 70, and you shouldn't be there with that sort of cholesterol. Apart from that, I would actually make sure that you do dietary modifications, you do exercise, you lose weight, and try to get your LDL. If you got no other risk factors, your LDL cholesterol should be 100 to 100. But I will not leave you with a cholesterol of 160 throughout your life if you actually don't do dietary modification, or if you can't get it lower than 130. And that's an important aspect. If you were 180, you would be on statins at this time. But because you said you're on 130 to 160, I still believe that you can do other things to get it to 100 to 120, which is our baseline for you, without any other risk factors. Okay.
Okay. While we're on Shivani, well, let's just take her 2 more questions. And then
so Shivani, do exercise, do take care of the diet, and I hope that you have your weight under control.
Okay. Just following on with these 2 questions, what are the heart checkups that Shivani needs to do post-COVID? I think you've already mentioned that, and after how long? If she gets a bit breathless climbing stairs, do you suggest a CT angio over echo and angio?
No, I don't. Not at all. One should just rush into CT angio without having reasons for it. And the reasons were that if Shivani had an exercise test and that came out to be positive, or had an exercise thallium scan, or had no other reason to be breathless, right, then I would say, okay, and she had risk factors already, then I'd say have a CT angiogram. But just as a primary investigation, I would not subject you to a CT angiogram just for the sake of breathlessness. I would look for causes of breathlessness through simpler tests. That includes chest X-ray, that includes lung function tests. It just might be overweight. It's just the fact that you're unaccustomed to exercise. You've been sedentary and you're just now working out. And 2 months later, wo saans phulna nahi hoga because you get used to it. So I think let's not think of CT as the first test. Let's think of CT as a important but relevant investigation.
And Shivani has 1 more question. And after this, no more Shivani questions, guys. My resting heart rate is 75. And soon after brisk walking, it goes up to 140. And on the cross trainer, it goes up to 170 within a few minutes. Is that concerning?
I think there was a Shivani who actually had an appointment to see me 2 weeks later, maybe. Shivani, you didn't decide to jump the queue by any chance. No. That's please. So let's have that question again.
Let's just go for So Samavi is asking, Doc, what is the Prince Bethel angina? My grandma was diagnosed. Is the calcium channel blocker she's put on to be taken for life?
Yeah. So Prince Bethel angina is when there are it does happen in ladies. By the way, heart disease in women is a whole topic in itself, and it's very different to men. But one of the important features also is this angina with normal arteries. There are no blockages.
Sure.
It happens more commonly in women, and the arteries are pristine clear, and yet without blockages, that symptom of reduced blood supply to the heart muscles happening. And that's assumed to be due to a number of physiological phenomena, including microvascular spasm, small arteries getting into spasms, small arteries getting into such physiological blockages that blood supply to the heart muscle gets impaired. Or even spasm of the large arteries, which suddenly occurs due to tension, anxiety, and other things. Just like, you have cramps in your muscles, and some people get those cramps. Well, arteries can get cramps and go spasm and causes severe chest pain, almost like a heart attack going to occur with ECG changes, and that's called Prince Bethel angina. That responds to these medicines, which are called calcium channel blockers, which relax the muscles of the artery supplying the blood to the heart. And that is the entity of Prinzmetal angina. It's a rare entity, so not very common, but its entity we keep in mind, especially when angina or severe chest pain continues to occur in ladies with normal arteries.
Sure. And Shibani wants you to know she's sitting with 6 other girls, which is why she's asking all the questions. Okay. Very entertaining, Shibani. Okay, from Zainab. Doc, we keep hearing and reading that taking calcium supplements without vitamin K2 also leads to calcification of heart arteries. So does that mean we don't take calcium supplements indiscriminately? Because calcium supplements also lead to heart artery calcification. Is there a correlation here?
It's an important question, and a question at the moment of investigation amongst cardiologists. What has been seen is, and yes, by the way, all blockages have calcium, and some blockages have more calcium than others, and calcified arteries is an indicator. Calcified arteries are an indication of blockages itself. That's why when we talk about CT coronary angiogram, we, as a first test, which is a screening test across the world, is CT calcium score. Some people may have heard about this, that you actually go in, don't have an angiogram or don't have any dye injected in the CT scan room, just scanning of the chest to pick up calcium. And if there are calcium in the arteries of the heart, then there's high likelihood of blockages. So what has been correlated is that heavy intake of calcium can lead to heart attacks, can lead to more calcification. And that's why you're so right. If I was to put it in simple terms, those who have osteoporosis, who medically need calcium, should continue to take calcium. But indiscriminate calcium use should not be done, because there are indicators that it can lead to calcified arteries and heart attacks as well.
Okay, great question, Zainab. From Kanchan, do heart patients need to be careful when doing intermittent fasting or fasting for 24 hours or more? And what would be the effect on heart, for example, in normal people if they were fasting or doing intermittent fasting?
So I think for the normal people with normal arteries of the heart, I think intermittent fasting is a fad. I'm sure it's unphysiological. It will have a whole load of effects on the body. It is non-sustainable. And therefore, I don't think that we should be actually looking at any fad diets. But for heart patients especially, and heart patients are also on medications. They actually have to take medications at a specific time. Their food habits have to be more regulated than non-heart patients. I would not emphasize. I would just ensure that none of my heart patients are on any extreme fad diets. Moderate fasting, X amount of fasting is fine. That's not what, but absolutely, even for my many patients who want to keep long fast, want to keep fast every day, I actually say, no, this is absolutely not. You actually have to have a regulated dietary intake and a regulated medication intake and a regulated exercise, and you have to maintain that schedule to remain heart healthy and not cause any complications to this.
I think that's a very valid point. The structure and the discipline and regularity, especially if you are already in that age group and that camp, I think that's very important. From Nandini, once you are put on statins by your doctor, can they be stopped once your cholesterol is under control?
I think I want you to all understand, just like it's the same for blood pressure, the same for cholesterol, and the same for diabetes, that no medication can be stopped. They're all controlling those parameters. They're not curing those parameters. And if you therefore stop any of them, the blood pressure or the sugar levels or the cholesterol levels will go back and rise to the same extent. Many people come to me and say, यार मैं इसलिए नहीं स्टार्ट कर रहा हूँ, मेरा बीपी तो आपने देख लिया 150 पे चल रहा है, बट मैं इसलिए नहीं स्टार्ट कर रहा कि मैं अभी 45 का हूँ, हमरे को जिंदगी भर दवाई खानी पड़ेगी, और कहते हैं कि एक बार दवाई स्टार्ट कर दी तो आप कभी छोड़ नहीं सकते. I say, what sort of a reason is that? You're going to take this medication for control. It's almost like saying कि मैं आज कार अगर मैंने ड्राइविंग सीख ली तो मैं जिंदगी भर कार चलाऊंगा, तो मैं आज से कार नहीं ड्राइविंग ही नहीं सीखता हूँ कि तेरे को कार ही नहीं चलानी पड़े. Does that sound a logic? So I say, yes, these are controlling drugs. Controlling drugs means that they are going to benefit you, and they are actually going to decrease your complications, and they're going to improve your outcomes, and they're going to prolong your lives. So you start taking them and you continue to take them, because otherwise it'll go out of control. So yes, these will control you. Your lipids will go back higher if you stop the drug.
Okay, great. Doc, this is a very common thing. It's a misconception, but I just want you to bust it. Sorbitrate. Everybody wants to keep it in case of emergencies. And what is your view on that?
Simple. It's very simple. Those who have heart problems and diagnosed and prescribed sorbitrate or drugs like accordingly drugs should keep it with them and use it when needed. Those who've not been diagnosed with heart disease should never take sorbitrate even during a heart attack. And let me explain to you why. Yes, sorbitrate, if taken for the first time, will cause sudden and severe drop in blood pressure to the effect that people can actually faint. So it's not a drug to be taken for a heart attack and kept at home कि अगर किसी को heart attack हो गया या मुझे कोई problem आई या मुझे chest pain हुआ तो मैं ले लूंगा. It actually can have disastrous consequences and not to be taken. Only heart patients who actually been prescribed sorbitrate would take sorbitrate either for a heart attack or for any other emergencies.
Okay. Go ahead. Wanted to add something?
No, I didn't want. I just hope that was clear that it can be a dangerous drug as well.
Okay. One more question from Roshni's just come in. The resting heart rate is 75, and on brisk walking, it rapidly goes up to 140, 150. So what are your thoughts on that?
It depends upon what we mean by brisk walking and for how long a duration and so on and so forth. Now, we see this commonly after recovery from COVID as well, a sudden rapid rise in heart rate. And we see this in those instances of individuals who are unaccustomed to exercise, who actually start even being very breathless on 3 minutes or 4 minutes or 5 minutes of unaccustomed exercise. So whenever we see a rapid rise in heart rate, we're not worried. All we worried about that individual is he unaccustomed to exercise. Let's leave alone the COVID issue. In general, it is those who are unaccustomed to exercise, because those who get used to exercising raise their heart rate slowly, and those who are unaccustomed to exercise raise their heart rates fast.
Okay, great. Doc, I think that's it. We are going to call it a day here. And I actually want to challenge myself and go over the 5 things that you said. So please tell me, because I know I missed it. Okay, you go ahead.
Bhavna, there's just one thing about that exercise and heart rate issue is that for men, we say the maximum required heart rate in which we need to stress, even for our stress test that we do, is 220 minus the age. Now for heart health, so let's assume that if there's a gentleman who's 50 and his 220 minus age comes to 170, then during exercise, we would like him in aerobic exercises to achieve only 70% of that 170 heart rate. And he should not go above 75% of that 170 heart rate. So that's the maximum tolerated heart rate, and then we say 70 to 75%. That's what we mean by aerobic exercises. For that would become under practically that maximum heart rate that he would achieve during his exercises to remain heart healthy is around 140 to 145.
Perfect. Perfect, Doc. Thank you so much, Dr. Seth. So let's just go over the 5 things that you said. You said 1 was exercise. 1 was...
First thing I said was smoking. I said
smoking yes, the first one was smoking.
Absolute taboo. And I want go get to everyone, so that's a taboo.
So the first one was smoking, cut it out. The second one was the exercise. The third one was bring your stress level down, right? Keep your mind relaxed. The fourth one
hobbies, etc.
Yes,
checkups.
Hobbies. And the fourth one was get your regular checkups. And that's very important, the checkups and the levels of checkups. So blood work is like your baseline for everything. And then depending on your risk factors specific to you.
Blood work, blood pressure check, sugar check for everyone.
Yeah, right. Okay, great.
And weight,
And weight, yes. And the fifth is, of course,
spirituality.
Spirituality and nourishing your faith and something greater than yourself. Dr. Seth, it has been an Absolute pleasure. And we can see from our comments and from everybody who's writing in that it's just been an absolutely excellent, so informative, fabulous. Thank you so much. And I also want to say that you are a mind reader, considering you did not have my questions and you were going where I'm going. So you have another profession available to you, Doc.
No, I think it was a great, I've had a great time with you all. I think it's a great, you doing such tremendous work in terms of every aspect Indian Women Network of the CII. CII itself is a body that I respect, and I think all of you are so passionate about your mission and objectives and responsibilities that you take on in every aspect of life. Today, I think we lost one of our greatest ladies of all times across the world, which was very sad, Lata Mangeshkar. And I felt terrible about time. Unfortunately, took her. It was COVID, it took her. But even at this time in her life, even just before COVID, she sounded no different to how she sounded almost 70 years ago. Her voice.
Yeah.
So it'll always remain with us. The voice, luckily, is going to always remain with us.
That's her wonderful legacy. And she's in the Guinness Book of World Records. She's sung in 26 languages. Quite a phenomenon, really.
Yeah.
Thank you so much.
Wonderful talking to you all. Wonderful talking to you.
I'm gonna hand this over to Zia. Zia, over to you.
Thank you. Thank you, Dr. Seth, for this amazing session. COVID has brought about so many questions on heart health, and we are so grateful that you've been with us today to answer all of them. Thank you, Bhavna, for putting together this series. You truly are an inspiration. We would also like to thank CII Northern Region and the Delhi Secretariat for their support. And finally, a big thank you to our fabulous team at CII IWN Delhi, who worked tirelessly to help us to put together this wonderful event. Thank you, everybody.
Thank you so much.
Thank you, and wish you all the very best. And whatever's left of the Sundays, have a great time. Stay well, healthy, and all my good wishes to you.
Thank you, Dr. Seth. And we're going to get you back for a women-only health chat with women and health. Thanks so much, Dr. Seth.
Yeah. Okay.
Good evening.
Bye-bye.